Hello everyone, this is Teach to London and I'm Jack Cooper, ST3 in Paediatrics, doing a presentation on neonatal sepsis. So today we'll be covering, starting off with a case that hopefully indicates a little bit about how one looks at neonatal sepsis, and then we'll be covering the risk factors, the way it presents, the management, looking at applying that to the case itself, talking a little bit about late onset sepsis as well, because GBS sepsis is one of the key types of neonatal sepsis that we encounter. It comes in two relatively distinct categories. Think about other variants and differentials that we should be considering this kind of illness, and then doing a SPA question at the end. So you're on your A&E placement, covering paediatrics, and you have a 38-week gestation baby that's 5 days old brought to you. And they've been brought in by their parents because they've just not been their usual self. They've been feeding poorly, not tolerating their feed, so having some vomits with some of those as well, not really settling down, and being irritable and much more upset than usual at home. So they had been feeding 15 to 20 minutes every 3 hours, but now that's kind of gone down to 5 minutes every 1 to 2 hours, so a significant drop to less than 50% of what's usual for the baby. And they appear, when you see them, and did appear to the parents, to be floppy, as well as pale and listless. There's a reduced urine output, so your triage nurse very helpfully does some observations, and you get a heart rate of 160, respirator 72, blood pressure as their prolonged cap refill time, and sats of 98% in air. And you're beginning to examine this child quite urgently, and you find that they do look pale. They are responsive, but quite upset. And there are some clear subcostal recessions. You've got partway through the exam and you hear normal breathing sounds and normal heart sounds. And there's a soft abdomen. And so the big question is, what do we want to do next, really? So what more information do we need in this case? What things about this make you think sepsis? Because hopefully you are already thinking sepsis, especially in a child of this age. And what should we do next? So it's time to talk about neonatal sepsis. So we use sepsis relatively freely in medicine in general. Obviously, what it really is a response that has an effect on end organs that you find in the presence of an infection. Usually bacterial, but it doesn't have to be. And essentially the same thing is the actual true definition of sepsis in neonates as well, but we will essentially treat any infection that is making the child appear unwell as sepsis until proven otherwise. And we will essentially treat any child that is unwell that we can't demonstrate isn't sepsis as sepsis until proven otherwise. So it can be caused by any number of pathogens, but very commonly is GBS. And GBS presents in two distinct ways. One is in early onset, which can be any time in the first 7 days, but typically within the first 24 hours, or sometimes a little bit longer than that. You can then get delayed onset GBS, which is anything over 7 days, and that can be up until 3 months of age, although typically, again, you start to get 2 to 3 weeks presentation. That is caught in a completely separate mechanism. So primary GBS, so early onset GBS, is something that you get from mother, usually due to vertical transmission, whereas it's kind of a separate infection that you could have caught from anyone if you get late onset GBS. It often still is apparent, but it's usually from the skin rather than from the birth itself. Now, GBS sepsis can be really nasty. It can progress really quickly. It's associated with meningitis as well. It's got a 2 to 5% mortality, but it's much higher in preterm babies, and it can be very high if you don't treat it quickly. It's not one you want to sit on. Other organisms that commonly cause sepsis in neonates are E. coli, famously listeria, although the rates of that are dropping, can cause a meningitis. You can also get staph. And then Hib and Neisseria were very significant organisms that now, because we vaccinate, there's much less of in the community. When it comes to treating neonates with sepsis, we look at things slightly differently to older children and to adults, in that we have to look at the risk factors, because neonates can't really tell us an awful lot about what's going on. Their symptoms are very non-specific, so we need some other things to help point us towards thinking whether sepsis is more or less likely in a situation. So risk factors include prematurity, so that's being less than 37 weeks gestation, the GBA status of the mother, so if we've got known GBS colonization or bacteria, then that definitely increases their risk of GBS transfers to the baby, and then you've got a much more significant risk of the baby catching GBS. Sorry, that's my own baby in the background. Then if you've got maternal fever, that is a risk factor. If you've got rupture of membranes that are prolonged, so now technically this is pre-labour rupture of membranes rather than prolonged rupture of membranes, and the exact length of time that it is varies from centre to centre. I'm just going to quickly make sure my file is okay. One sec. Some places would say 24 hours is prolonged. 24 hours, but it's just to kind of give you an idea that it's pre the actual labour mechanism itself. Lots of places also say 18 hours, so there's a bit of variability there. If you've got a previous sibling who needed to be treated with IV antibiotics as sepsis, that's a risk factor. If there was GBS in a previous pregnancy, that's a risk factor. And if there are signs of chorioamnionitis, that should be in red really. So the things that are in red there are red flags. So with risk factors, you need 2 risk factors or 1 risk factor and a symptom or a sign, and then you should treat this as sepsis. If you've got 1 red flag, then you should treat this as sepsis. Essentially, if you look here, if the mother is treated as septic, so if she's just got a fever, there can be other reasons for that. And just having a fever doesn't mean that mother has sepsis, and if that doesn't mean that it's likely that a bacteria will cross the placenta. But if mum is being treated as septic with IV antibiotics, you have to treat the baby as septic. If there's a twin that is also unwell, then it's very reasonable to suspect that they've got the same environmental factors as the baby you're looking at. So if one twin is treated for sepsis, the other twin is treated for sepsis. And the signs of chorioamnionitis here as well is something that if you think that there's an infection of the delivery mechanism to a baby, then the risk of sepsis is much higher, and you will always treat that. The kind of symptoms that we're looking at are, as you can see here, very wide. So poor feeding, and that includes not being able to tolerate feeds, and in admitted babies, increased aspirates if you've got an NG as well, it comes into that. Poor tone, having altered conscious state, so being sleepy or irritable, having fever or hypothermia, and those again are put in red. Although in reality we do make sure that we don't think it's environmental. So if you've got high temperature or a low temperature that perseveres, we call that temperature instability, and that's a sign of sepsis. That's enough to treat in itself. Changes in the breathing pattern that are noticed by the parents, jaundice within the first 24 hours of birth, there's one to consider sepsis. Certainly seizures, and then when you actually examine the child, if they've got respiratory distress, so recessions or tachypnea, and it's lasting more than 4 hours after birth without some other obvious cause, and even then most places would advise to cover for sepsis just in case, or if there's so that's a reason to start antibiotics in itself. Otherwise, you look at things like hypoxia, tachycardia, apneas, shock. Obviously is one to treat immediately, as would needing to give CPR. Things like changes in blood sugar regulation, local signs of infection, and bulging fontanelle. These are all reasons to start antibiotics in a baby. And as you can see, the majority of these present in the first day of life, so more than 90%. That's an early neonatal sepsis. Think about a different picture if it's a bit later on. And then the other thing to think about here is to clarify some of these things. So if mum's got a fever, just think about whether that's down to something like having an epidural or having prostaglandins. These can both raise temperature. Post C-section, it's normal to spike a low temperature. So these aren't reasons inherently to start antibiotics. If mum's had a temperature and it's actually outside of 24 hours of birth, so 24 hours after birth or 24 hours before birth, then that isn't inherently a reason to start the baby on antibiotics as well. So you just have to rationalise these things.